with the development and application of the larger size percutaneous valves such as the 29 Sapien, there became a number of reports beginning in 2013 through 2019 looking at the application of conventional off-the-shelf valves to address patients with large outflow tracts after transannular patches. However, the problem with that is we're all familiar with, and I'll go into some issues about the physiology or the morphology. The transannular patches can be quite patulous and have a variety of different shapes and sizes, which really doesn't bode well for the larger population that we actually address. So only about a quarter of the patients with RVOT dysfunction have conduits. Almost two-thirds have surgical outflow tract patches, which really are not amenable to a great number of the conventional technologies. So what valves are out there that are being developed? This is a short list. There are many more, and I'm just going to talk about the top three: the Harmony valve, the Altera, and the Venus P valve. These are designed specifically to address the outflow tract morphology after a transannular patch. So the Harmony valve, as many of you are familiar with, is a porcine pericardial tissue valve. It comes in two sizes now. There's a 22 millimeter diameter valve. Whoops, wrong way. There's a 22 millimeter valve, which is called the Harmony 22, very ingenious of Medtronic. And that valve has those dimensions. It's about 5.5 centimeters long. The distal or pulmonary artery end is 33 millimeters, and the proximal RV inlet area diameter is 42 millimeters, which then causes a problem because it only fits only so many morphologies that are available. The delivery system is 25 French, and it's delivered in a similar way as AAA grafts. This is a more detailed picture of the construction of how the valve is sewn into the chamber, or the middle part of the implant. There is now a larger size valve called the Harmony 25 because the valve diameter is 25, and its dimensions are slightly different. The distal PA end is 49 millimeters in diameter, and the proximal inflow 52, which millimeters, which allows you then to apply this to a larger cohort of patients for implant with larger patulous outflow tracts. So there's very little data out there on the outcomes of these valves, and I just want to share with you the data from the early feasibility study from the Harmony group, which was specifically designed for the Harmony 22 dimension. And this was a engineering study specifically designed to look at the loading conditions on the device, and the follow-up is now going through 5 years to look at the clinical outcomes. And Mark, Eric, and I were one of the centers, along with John Cheatham and Nationwide and Lisa Bergerson, excuse me, at Boston Children's. So the one thing that we learned, as you know, I'm old enough to remember the clamshell for ASD devices, and we didn't know anything about the anatomy of the atrial septum. I mean, we thought it was just a hole in the wall, and just put a device in. We learned very quickly, as Zahid mentioned, that it's a very complicated structure. Well, the outflow tract is a dynamic environment, and it changes in dimensions during the cardiac cycle, and its morphology and its dynamic changes affect the choice of what you can put in there safely. So one of the problems is picking the right valve and picking the right patient for that valve. The Medtronic engineers came up with a very interesting way of looking at the diameters of the outflow tract, and by looking at the perimeter of the perimeters of the outflow tract, and this was obtained from CT scans. So if you look at this white line, this is the diameter or the perimeter plots of the device unconstrained. And during the cardiac cycle, the pulmonary arteries enlarge during ventricular systole, and during ventricular diastole, they get smaller. These devices don't have hooks. They depend on interference from the wall of the outflow tract to keep it stable. So there has to be a certain amount of compression of the device in order to keep it from embolizing. So one then looks at the amount of compression or the diameter of the outflow tract during the various stages of the cardiac cycle, systole and diastole, and see how much compression there would be. And in this case, this is during ventricular diastole, so the pulmonary arteries are smaller, so they would be here. And that's during ventricular systole, so the pulmonary artery is larger, and so the perimeter is larger. But in this case, you'd still have compression of the device in the distal aspects. So there was an arbitrary decision to use 15% compression. We sort of pulled it out. The engineers sort of said, well, that sounds right, about 15%, as most things are in medicine. And this is an example of a patient who was considered appropriate for the study. Again, the non-constrained device is in black, and then the systolic and the diastolic diameters of the outflow tract. So that device would be implantable into that patient's outflow tract. We did simulations in order to have what the appearance of the implant would be in systole and diastole, and we made three-dimensional SLA models, so we would have in our mind's eye where the devices would sit as you would do the implantation. And this is an example from one of our cases showing the implant being positioned. This is just a simulation in one of the models of how it unfolds, and then the device is unscrewed at the proximal end, very similar to the AAA grafts. It turns out that the technique of implantation, those of you who have used the Harmony or the Altera, the technique of the implantation is really straightforward, because by the time you get to the point where you're implanting this, you know it's going to fit. The most difficult part of this procedure is picking the right patient for that size valve. So the early feasibility study evolved into a pivotal study, which was designed for 40 patients. That pivotal study has been completed, and the company is applying to Health Canada and the FDA for a continued access study for wider distribution. This is a list of the number of patient PIs that are involved, including Allison at the Mayo Clinic, who's had some experience with this. So just to give you a notion of how difficult it is to pick the patients when you're constrained by the size of the valve, the three sites, we went through about 350 MRs, 350 different patients, that the PIs felt 66 of them were appropriate for the implant. Of the 66 that we all thought were appropriate, making the measurements, they actually dropped out. When the engineers did, 46 of them dropped out because they weren't appropriate. So there were 21 implants, and we have 3-year follow-up data on the durability of the implant, which is really very interesting stuff. The demographics are pretty straightforward. Most of them were tetralogy PS with transannular patches. All of them had severe PI, and 85% stayed in for only 1 day after the implantation. This is the 3-year data from the study cohort. Pulmonary regurgitation is unusual, trivial in only 2. Similarly, paravalvular leaks, very difficult not seen very often, and there is no significant increase in the gradient. These are echo Doppler studies from the pre-implant to the 3-year follow-up. However, things don't always work well, as we know, when we implant things. There are complications, and this was an adjudicated adverse event committee. One patient, the device fell out. It was undersized and had to be taken out. And there were there was a frame fracture in another patient, and those 2 had to be surgically explanted. And then the 2 patients required intervention because they had developed some in-stent stenosis, which was really the problem because we didn't understand the mechanism of that. These were the 2 patients. They all had melody valves implanted within the framework of the harmony valve, and they all had good hemodynamic results. So because of the development of these 2 patients' in-stent stenosis, the DSMB decided to require a further CT scan on the additional 16 patients. So we have follow-up CT scans at 3 years in 16 patients, and we looked at what the morphology or the mechanism of tissue ingrowth was, and we looked at the location of the coronary arteries if we could. So this is a typical CT scan. Here's the device implanted. These are the 6 nodes of the device, and we chose 3 nodes to make the images in looking at the diameters and the circumferences and how much tissue ingrowth at those 3 locations. And this is sort of a plot of the change in the diameter or the luminal area in this graph from the first discharge CT, which was done about a week after the implant, to the follow-up, now 3 years. And what you see primarily is that there's a loss of luminal area at the 2 ends with very little change in the area of the valve where the valves are sewn in. And if you look at the morphology of how diaphragm conduits are incorporated into the outflow tracts or into vessels, you actually see that there's data that shows that there is ingrowth of intimal tissue at the 2 ends with very little change in the center of the implant. And this is a CT scan of one of the Harmony patients, and this is very typical appearance of the coronary artery. Now, the Altera adaptive pre-stents is a different concept. So here, the manufacturer, Edwards, is using a bimodular implant technique. What they're doing is that they're giving you a stent, which can then be implanted in the outflow tract, and then put a 29 millimeter Edwards valve with a landing zone, and sort of this appearance. The diameter of this is about 40 millimeters. It comes in one size, although the company is changing, is going to offer us a shorter one as well. This is sort of what it looks like when you implant it. That's the device itself. It is implanted with a slightly different technique than the Harmony valve. It's not attached. You don't have to unscrew it. It's just more like that stent you try to put into the thing the other day, the protege stents. It too has gone through an early feasibility study that Evan Zahn was the national PI at 4 sites. That has been completed, and they are beginning their pivotal study. There's limited data on the long-term follow-up. This was Vivian Dimas presented this data at SCAI, looking at the 15 patients. These were the criteria for success: appropriate deployment, no explant at 1 day, low RV pressures, low gradients. and they were achieved in all of the patients, the endpoints for the efficacy of the implant. Now, the final valve I just want to mention is the venous P valve. It's made in China. It has a completely different concept of implantation. It's more like a core valve, if you will. It takes up the entire outflow tract. It's a porcine pericardium that's sewn onto a nitinol frame. This is the pulmonary artery end, and it's designed to fit into the confluence, and it has a similar kind of a release mechanism as the Altera, and it up to a 24 French delivery system. It comes in a variety of lengths and diameters that are chosen based on balloon sizing and CT scanning. It has some areas on the device to help you locate it in the, when you implant it, particularly the location of the open ends. You choose the device based on the diameter of the outflow tract and the length, and as you can see, the company comes in there's a number of different combinations and sizes that you pre-order for the implant. Again, this is a typical sizing application, main pulmonary 26. They recommend 4 millimeters or so larger, so it would implant, it would fill up the outflow tract. This is Shaq Qureshi along the these slides to me. It's a very long device. It's a little stiff, but you can get it to the target zone, and the implantation is fairly typical of the other types of devices. There's very limited long-term data on the implantation. 55 patients, this is the initial Chinese experience. This is a 1-year follow-up data. 2 patients died, one of infective endocarditis, and 3 other patients developed infective endocarditis after the implant, which is a bit concerning. Echocardiographically, they all had very good hemodynamic outcomes with low gradients and absence of PI, and what you would expect from the effect on the right ventricular outflow tract. This is a similar kind of valve that's being developed. I think John Cheatham is involved with this to some extent. It's also a self-expanding nitinol frame that is now undergoing its first clinical applications. Again, the same type of delivery system, unleashing, pulling back a cover to open it up. So there are a number of designs being addressed around the world to address this very dynamic and contorted anatomy in the right ventricular outflow tract. All are being tested and appear effective, and I don't think there's any one single device that can address all the anatomies, but there's a lot coming over the horizon. So thank you very much.